So ILD and IPF, unpredictable diseases. Because one day these people can be doing fine with a little shortness of breath, and then they fall off the cliff, they get a pneumonia, they get the flu, something happens, and next thing you know, they're in your ICU on a ventilator. And it's really, really hard once that's happened to kind of get them better. Not saying it doesn't happen, but it's very, very difficult.
It happens.
It does happen, exactly. You know, you go from here and you're feeling fine, and then it's like someone hit a switch. And that's what people tell us. It's like that, and they're in the ICU on the ventilator and on 100% oxygen. So with IPF and ILD, the best thing we can recommend for you is if you are diagnosed with this disease, you should be referred at that time. Even if you're not on oxygen, even if you're not to the point where you need a lung transplant, it's better for a lung transplant center to meet you. That way we can start kind of following you. That way, if you're not even listed, 5 years down the road, you have an exacerbation, we can say, we know him, we know what's going on, we can get him on our list in so many days, we can get him transplanted, or her, okay? The problem is what happens is people get diagnosed with pulmonary fibrosis, and they don't get a referral to a lung transplant center. And then when they do, it's when they have the episode where they fall off the cliff, and we get a call saying, we've got this person on our ventilator, they're on 100% oxygen, and they need a lung transplant. Well, I mean, what do we know about them? We don't really know anything about them. We don't know if they have heart disease. We don't know if they have the liver disease. We don't know if they have kidney disease. We just don't know them. So we cannot, offer our services if we don't know anything about you. Because it's very, very difficult to do a workup when somebody's in an ICU and they're so unstable on a ventilator that we can't take them down and do CT scans, or we can't take them down and do a cardiac catheterization, or we can't do all the things that need to get done for a lung transplant workup. So it's very difficult. SBC is what we're kind of following with that. And if we see a 10% drop in 6 months, that's when we start thinking, we're heading down that path, we need to go ahead and start listing, okay? And it may be that in March, you're here, and then you're 10% in April, and 10% more. Well, if you keep losing 10% every month, you're going to be in trouble before you know it. Cystic fibrosis, now no one here said they had CF, so I'm just going to kind of go through it real quick. It's a genetic disease, has multiple different mutations. Some people with CF have really bad lung disease, some people don't have as bad lung disease. Some have more longer pulmonary therapies or do better with pulmonary therapies than others. The big thing with CF is that we have a new class of drugs now, CFTR modulators, that are improving the way that the CF lungs work. So they're not getting as many exacerbations, and they tend not to get as sick as fast. So it used to be that with CF, they would give you a life expectancy of 20 years, from birth to death. And now we're seeing CF patients live into their 50s and 60s without a lung transplant, which is great. I would love to not have to do lung transplants for CF. If we could find a cure for this genetic disease, that'd be perfect, because that's just one less population that we would have to transplant, and we can give it to people that we don't have all the good drugs for. Like I said, working better. Transplant referrals for CF should occur when the lung function is less than 30%. And that usually, the CF teams, if you don't know, CF has its own teams of people that work on this. And usually if they start seeing one of their patients start to drift down in lung function, they get a referral to a transplant center, quick. So the evaluation itself, it consists of multiple medical exams. It's tests and procedures and assessments. It usually can be done in 3 to 5 days. Now that's not 3 to 5 days straight, sometimes it's broken up. It really depends on the patient. If the patient thinks they can do 3 days of tests in a row, that's great. If you don't, we can break it down into 5 days and do a couple on this day, a couple on this day, a couple on this day. It really depends on the patient. Preferably done on an outpatient basis. We will do an evaluation on an inpatient if they're critically ill, but at the same time, we're not going to get the best bang for our buck if we're doing it in somebody who's so sick that they can't really participate in the evaluation. So when we send our neuropsychologist in and the person keeps falling asleep, that's probably not going to be a good exam. It's probably not going to give us the information we need. So it includes a complete medical and physical exam, medical history and physical exam. this is going to be one of the most intensive in medical exams you've ever had, okay? Because it's not just one person, it's going to be multiple people coming in. And I see somebody shaking her head. It's one of the most intense exams you've ever had, because not only will our pre-transplant coordinator see you, our social worker will see you, our nutritionist will see you, and they are going to ask you the same questions. And then they're going to get together and go, what'd they answer for this? What'd they answer for that? And then the physician's going to come in with all this information and kind of grill you more. That's not anything that, we don't trust anybody. We got to know before we start getting too far into it, okay? Because if there's a red flag on day 1, there's probably going to be red flags on day 5. Labs, we take a lot of blood. I mean, a lot of blood. I actually walked with a patient through the evaluation one time, and I was like, yeah, we probably should cut back on that. But we need that much blood so we can run the testing that we need. And then we give you a lot of radiation therapy. X-rays, CT scans, DEXA scans, ultrasounds, everything that you can imagine we do. Then we have everybody kind of see you that needs to see you. Sometimes we don't know that they need to see you until after we've started this. So a lot of times we'll get an echocardiogram and your ejection fraction will be low, and we'll have to have you seen by a cardiologist. If you have an infection that we weren't aware of, we have to get you to see an infectious disease specialist. If there's something that we think we need to kind of get dentistry in, we'll get dentistry in. There's a lot of people, we don't just leave it to the pulmonologist. There's a lot of people that folks see when they get a lung transplant evaluation. And the psychosocial evaluation, the reason I want to talk about that the most is because I think that's the most intense. And we at UVA truly believe that the psychosocial evaluation is key. Because there have been a lot of times when we've had people come in and our social worker has said, hey guys, there's a problem here. And we've been like, oh, no, it's fine. And we find out after transplant, yeah, there really was a problem. And we should have probably addressed this before transplant. So we've gotten really, really tough with our psychosocial evaluation. So our psychosocial evaluation includes a social worker, clinical social worker, as well as a neuropsychology testing. And now neuropsychology testing is 4 hours. And it's memory, it's recall, it's kind of overall how you're feeling, how you're doing, how do you cope with stress, and a bunch of what ifs. I know that they go, well, what if this happened? What would you do? How would you handle that? And sometimes patients go, I can't believe they just asked me that. And it's just so we can get a feel for how things are going to go when we call you at 3 o'clock in the morning and say, we have a lung available for you. We need you to get in the car and drive 3 hours to come to UVA. And I've had people hang up on me. I've had people say, yeah, I'm not ready for this. I can't do this right now. That's a problem. So we want to know about that before. We also want to know if there's something that we can do to control anxiety or depression. And that's where our neuropsychologist comes in, and she is key. She or he, depending on who's doing it. But they can help us address these things. They also test how you learn, because education is going to be very, very important after transplant. It's important before transplant, but you're only going to hear about 10% of what we say. After transplant, I'm going to send you home with a book that's about that thick and give you 1,000 instructions that you have to follow to a T, no exceptions. Right, guys? So I need to know how you learn. So do I need to put it in PowerPoint form so I can talk to you about it? Do I need to put it in writing? Do we just need to sit and have a question and answer period? Those are all kind of things that we get in our psychosocial evaluation. Infectious disease screenings. So certain infectious diseases we know that we can't transplant people for. But we also want to know what their infectious disease history is. Here, it's very interesting. We're coming into an age where there are a lot of new things that we can treat, like hepatitis C. So a lot of people that 10 years ago came for lung transplant and got diagnosed with hepatitis C, we would have to say, unfortunately you have hepatitis C. We don't think we can do a transplant with that because we're going to cause you more problems than we will help you. So we're going to have to go ahead and pass on it. Now we have treatment for hepatitis C, and we can eradicate hepatitis C in just a few months. So it's kind of being a game changer. As far as I know, we're not doing hepatitis C transplants, but we are looking at patients that have been cured and considering them for transplant right now. Now, the one big thing is HIV. Of course, we have no treatment for HIV. We have treatments for it, but we don't have cures for it, and there's still no consensus on whether or not we should be doing lung transplants on HIV patients. infectious disease screening includes a lot of things, depending on what infection you have. So we could ask for sputum, we could ask for stool, we could ask for blood. It really depends on what our infectious disease doctor says is the most important thing for us to get for you. So when do you list somebody for a transplant? We list people for transplant when we sit down in a big meeting at 6:30 on Thursday mornings. You can imagine how lively that meeting is. With a big pot of coffee and a big stack of charts. And we sit there as a team and we talk about it. Who saw the patient? What were their feelings about it? Do they meet our criteria? Do we feel like it's safe to do a transplant? That team is not one person. It consists of 2 pulmonologists, 3 thoracic surgeons, a cardiologist, an infectious disease physician, social worker, neuropsychology, respiratory therapy, transplant coordinators, financial coordinators, nutrition, but it didn't fit on my slide. A lot of different people have a say, and any one person at that table can say, stop, we need to look and see what this is all about. And we've learned that through the years, okay? So when my social worker, Mr. Potts, says, stop, this is not a good idea, we need to address this, we stop. And we come up with a plan of what we're gonna do to address it. If the thoracic surgeon says stop, we have to listen and we have to say, what do you need us to do to make this better? And if they say, we can't do this transplant, then we say stop and we call you, okay? So it's not just one person making a lot of decisions, it's a lot of people making one decision. So when you are ready to go to committee, after committee, you go into 4 different categories. Ready for transplant, that means actively waiting on the list, like, I'm sorry, Wanda. I couldn't remember. I wanted to call you Wanda, but I knew that wasn't right. Wanda. She's actively on our list. So she's actively listed. My counterparts could call her right now and say, hey, I need you to come to UVA. Could happen anytime. She's got her phone with her. That's part of that education. Keep your phone on and with you. Defer a final decision based on unresolved issues. So that's when one of our team members says stop. And then we have to kind of go back and reassess the issue. A plan of care, because some patients just are not candidates for transplant. And we may get all the way through the evaluation and find something like HIV or syphilis or something like that that says they're not a transplant candidate at this time. Let's try and figure out what the plan of care for them should be. And then refusal. Very seldom does someone get all the way to a committee and then get refused for transplant. Now, it does happen because there's something that comes up in between the time they go through the evaluation and the time they're taken to committee, but it's very seldom. Usually we find out. If the decision is made, it is discussed with the patient who makes the final decision, okay? Remember, if we accept you for lung transplant, it's not us that has to make that decision, it's you. We call you and say, are you ready to be actively listed? And sometimes people say, I'm not, or can I hold off for a month, or can I, wait till my grandson's graduation, or my daughter's, wedding? That's fine. Whatever it is that you want to do is fine with the transplant. So there's a big system called EUNOS, and I know that you guys have had somebody from EUNOS come to talk to you here at this meeting in the past when I looked through your website and looked at your meeting minutes. That it's a computerized algorithm that my math teacher wife, who teaches calculus, doesn't fully understand because it doesn't make sense to her. It's not a mathematical component. I'm medical, I don't understand it. So there's a guy sitting somewhere that's probably a statistician who kind of plugged in a bunch of numbers and said, hey, look what this does. And that's kind of where this came from. But it is validated. It's a team of pulmonologists and transplant surgeons have said, this is the best way to kind of rate these people. Who's the sickest? And that's what it is. It's from 0 to 100. 0 means that you're not that sick. 100% means that you're as sick as they come, and that's who's going to get the transplant first. The average falls at our center around 40. So that's not super high, but every once in a while we'll get somebody who gets sick that's on our list. They get sick, they come into the hospital, we bump their score up, and they'll be in the 80s. Mr. Moore was one of those guys. He was really sick when he called